Thank you very much for inviting me. I'm going to try to give you a bit of an overview of different approaches to using modeling to inform policy, programs, interventions, particularly in population health. I'll show a number of examples to illustrate what I'm talking about. Just for full disclosure, I hold appointments in a number of policy relevant and advisory positions, and I'm really at an institution at Brookings that sits at the intersection of policy and science, so I spend a lot of time thinking about how scientific models can and should be used to inform policy choices and interventions. I'm also going to start with what is a model. We heard one definition that was a very nice one that I hadn't previously come across just a minute ago. Here are two more definitions at the top that are actually quite similar. The third definition is interesting because it says that everyone is a modeler. And that anytime you're making a projection about how something you're doing to change a system will play out, you are in effect modeling that decision. And many of those models are implicit and are not made systematically explicit. And that is in fact the first reason on my list of why we might build models of the kind we're going to be talking about today to inform policy is by making our implicit mental models explicit, we gain a lot of ability to test the underlying assumptions that are built into them, to explore the boundaries of when they are or are not good representations of the systems that we care about. And because the systems we care about are very complex ones, tools like computers and math can help us do that in a way that can be very difficult to do in a mental model. The next reason on my list is also been mentioned already, which is that appropriate real-world experiments may be hard. And in many situations we care about, doing experiments may actually be unethical. It may be prohibitively expensive. It may be very slow. It may be practically very difficult. And in all of these situations, models can help. It can also be the case that heterogeneity means that what we learn from something like a randomized control trial may have limited generalizability to many other contexts, which we can't study. We can't study them all. There may be heterogeneity across individuals, across contexts, and across time. Which brings me to my next point, which is that when you intervene in a system, what you do is likely to change more than necessarily just what you intended to change. And this is because many other parts of the system may adapt in response to what you've changed. And some of those adaptations may take a long time to be visible. Here's a nice quote from a recent Institute of Medicine report that's about a particular kind of modeling called agent-based modeling and its applicability to tobacco policy. And this is a nice illustration of the point that I'm trying to make here. Some of these adaptations in a public health context are biological. So there are things like the evolution of resistance to a pharmaceutical intervention by a virus. They might be purposive, like if we intervene to restrict access to soda, but people stop drinking soda and start drinking Gatorade instead, or another sugar-sweetened beverage. It's not clear that we've actually addressed the problem as intended. And they may actually be strategic. So if we intervene in tobacco control, oftentimes there is a strategic response by the tobacco industry to what we've done. So those are all kinds of adaptation that are important. Next on my list is management of uncertainty, and models can help us think about alternative worlds that have not been observed yet and cannot be observed yet. What next year's flu strain will look like, what might happen if we implement a brand new policy that has never been tried before, like raising the legal age to purchase tobacco to 21, which New York City recently did. Models can help us think about these things, which sort of by definition we can't think about with data, with existing data. And finally, we might want to use models where the process of implementation or even of decision making itself is the focus, and we want to study those things by taking a step backward. And for population health in particular, I think it's fair to argue that these are all applicable reasons because we're dealing with multiple mechanisms and determinants, lots of diversity, lots of interaction effects, lots of adaptation in many, many situations where experiments have practical or empirical limitations and lots of uncertainty. So models have really been applied in a number of ways to help guide policy program and intervention design and decision making. And I want to outline a typology that I will then illustrate with some examples that may help guide your thinking for the rest of the day. I think there's really three ways models get used, and they're not mutually exclusive, and some models are doing more than one of these. But the first way is to use models prospectively to try to understand in advance what the consequences of an intervention or a policy might be, those that are intended and those that are unintended. And this is sometimes referred to as in silico experiments as opposed to in vivo or in vitro. This is in the computer. We're going to do some experiments, and we're going to try to understand what will happen when we intervene. And models like this can be very good at elucidating not only unintended consequences, but potential trade-offs or synergy between different policy choices in a complex world. They can help to coordinate policy interest and policy action across many silos in government or the policy world or in science. But as was said earlier, these models, of course, are not crystal balls, and they don't eliminate uncertainty. They just help us manage it, and they don't replace judgment. The second, and so I'm going to show you some examples of models used in this way. And the first example comes from a large NIH-funded modeling network, which I was part of for many years, called MIDAS, the Models of Infectious Disease Agent Study, that had multiple independently developed models, some very big, some very small. And the goal of most of these models was to inform policy choices and intervention design prospectively, in just the way that I articulated a minute ago. MIDAS had very high scientific and policy impact. It received the Health and Human Services Distinguished Service Award for its contributions, including some really important contributions during the H1N1 flu pandemic that we had a couple of years ago. And these models were able to help think through what some of the implications of choices made during that epidemic, things like closing schools, closing airports, distributing antivirals, distributing vaccine. And these are choices that had to be made sort of in real time with high uncertainty and without a lot of data necessarily to directly guide them. But these models were able to leverage quite a lot of data that was available, data on flights taken everywhere in the world, data on sharing of patients and doctors across large hospital chains, data on social networks and social contacts and social structure, and sophisticated representations of individual behavior, and even a lot of biological data about how the disease might progress in individual people and affect contagion. And these got wrapped up into very large-scale models, which could be used for policy purposes by essentially providing this kind of computational laboratory I mentioned earlier. So these are simulation models running on a computer that are simulating the spread of a flu pandemic across the globe or across the country. And then what you can do with a model like this is to systematically explore many intervention choices and to understand how the pattern of the spread of the epidemic may be altered by what you do to combat it. The other example I want to talk briefly about, also from a public health context, is some relatively new work that I'm doing that's driven by the FDA's interest in models to inform decision-making about point-of-sale policies in tobacco control, another important area. And this is, again, a model that draws on a lot of existing data to try to understand what the consequences of these retailer-based policies might be, how changing the spatial distribution of retail and the properties of that retail might play out. And in addition to helping to answer that question, this model also helps highlight what it is that we know and what it is we don't know and need to know urgently. And that's an important role that models can play along the way. So this model, to give you a flavor of it, is designed to understand how specific changes in the distribution of tobacco retailers driven by specific policy options might affect the behavior of cigarette smokers and their purchasing of tobacco over time. And it's designed to explore trade-offs between, for example, zoning strategies and licensing strategies. It's designed to understand how large the effect of a policy might be, but also how quickly we might expect to be able to see it and measure it, and how we'll know if a policy has succeeded. It also considers unintended consequences, particularly distributional consequences, in which we may actually reduce overall access to tobacco, but actually worsen disparities that are already present. And to give you a flavor for how this model works, I will again show you the model in action here, if I can make it work. There you go. So this is a simulation model of a physical geography of road networks in which people are moving around the space, purchasing tobacco, and we can change the features of that tobacco retail environment and learn things about how individual responses will change over time. Okay, let me see if I can make the presentation come back. There it is. Okay, very good. All right, so this is a model called Tobacco Town. If you're interested, I'm happy to tell you much more about it later. The second use of models that I want to highlight is the use of models retrospectively to look at interventions that have already been tried, policies that are already in place, and to try to understand how they work, why they work or don't work, and to leverage that knowledge to help us think about replicability or scaling in other places. So in this context, what we're doing is we're trying to understand the why question. Why does a particular policy have the impact that it does, which is not always clear in many real-world policy situations. So an example of that is in the case of obesity prevention at the community level, which is a hot area right now with lots of investment being made in these kinds of interventions. And some of them work extremely well, but some of them don't. And some of the ones that work the best don't seem to replicate when they're tried in other places. And it's not well understood why that is the case. Understanding that, we hope, will help us to design interventions that are appropriately tailored to context and to leverage what we have learned from the existing evidence to design new and better interventions. So this is a project called Compact that is funded by NIH also, and this is a model, a development of a model in which we're looking at completed successful and unsuccessful interventions, trying to understand how they worked, and then testing those intuitions with ongoing interventions where we're essentially using the model to predict what we expect to happen in different circumstances and testing those predictions. And then at the end, we're flipping around and using the model prospectively in that first way I elucidated to actually design a new intervention and field it based on what we've learned from the model. There are many other examples of models used prospectively or retrospectively to directly try to address policy options. If you're in many fields, there are many examples. This happens to be a list of some things that I've worked on that are of this flavor. And I'm happy to talk more about any of these if they interest you. They include corruption, crime waves, retirement decisions, childhood literacy, et cetera. There's a third way of using models that I want to highlight too, and I think it's less of a focus today, but I think it's a very important thing to bear in mind as we delve into the world of modeling. And this is that there are many models which don't explicitly model any policy, and which no policy or intervention is represented, but which nonetheless have implications for policy and intervention design. And these are models that are often focused on etiology, on understanding the mechanisms that are at work, and understanding these mechanisms can actually not only help us have a better understanding on which to base our policies, but they can also highlight critical data gaps which may, if we address them, may help us to reduce uncertainty that we face as decision makers. And so again, I'll show you several examples of this use of modeling. The first actually connects back to the Midas models, which were used prospectively, as I said earlier, but Midas invested a lot of effort in foundational work to close a lot of the gaps and uncertainties that were present in the early models, and there was a lot of emphasis on thinking about adaptive behavior, about people who refuse vaccines, about people who during an epidemic won't show up for work or will keep their kids home from school or will run away, which are things that all real people do, and that change the implications of the model. So getting that right proved to be very important, and there was a lot of foundational investment in that. Another example, which I'll tell you about briefly, is some work, another NIH-funded study that focused on understanding the neurobiology of eating, and in particular how preferences are formed and may persist over long periods of time, with a particular attention to early childhood as a period of preference formation for food that colors later obesity risk. It turned out that some of this work, although it did not model any policy, had important implications for identifying windows of where to intervene and how to go about intervening and how the same intervention might work differently for different people. And understanding that can be incredibly valuable for designing more effective interventions. I'll show one more example, also an NIH-funded study, that here is studying how social norms change about obesity and how that process it gives hints about how that process might be leveraged to actually design more effective interventions that are social in nature, that are aimed at social network structure and take seriously social influence in obesity. So I want to wrap up in just a minute here by sort of leaving you with the sense that both there's lots of promising ways to use models to inform policy, but also with the caveat that it's not easy to do, and it's particularly not easy to do well. And there are many, many great case examples of models that successfully informed policy and in a way that was positive. And you'll hear about a great many of those today, but it's important to know that that's a sample from a larger population of models that were very good but failed to make a difference in decision making, or models that made a difference in decision making but turned out to be flawed in important ways that had side effects as well. So it's just good to have that big picture in mind and to know that in order to do modeling well, both so that the results are dependable and reliable and meaningful, but also so that it actually answers the questions that policymakers and decision makers have, there are best practices that should be followed. There's a number of excellent publications out there on what these best practices are. I don't have time to go into great detail on what all of them are, but there's a set of best practices for model developers, some of which involve, if your goal is to address policy questions, you need to engage early with policymakers, with decision makers, and make sure that the question you're answering is one that actually matters to decision makers. And if you're answering quite a different question than policymakers care about, or if your endpoint is very different, if your model stops at BMI, but policymakers want to know about dollars and morbidity and mortality, then you haven't necessarily addressed the question that is needed. And so clarity about the question goal, setting model boundaries. The hardest part of any model is deciding what to include and what not to include. You'll hear lots of discussion of that later today. There are important best practices there. Careful implementation and testing. A common question by decision makers and policymakers is, why should I believe in what this model is telling me? And part of how you address that is to have done a good job testing your model and used a lot of care in implementing it. And part of it comes back to what I said earlier about engaging with decision makers and policymakers early in the process so that they have a deep understanding of the model and become stakeholders in the model development in a way that gives them a lot more intuition about why the results that are happening, especially when those results are counterintuitive. So to give you an example, several of the Midas models I referred to earlier had very counterintuitive findings, including things like closing schools could be a really bad idea because it turned out that lots of healthcare workers in the United States are single parents who don't have good child care backup plans. And you might expect very large levels of absenteeism if you were to close schools on a widespread basis. Or if you have very limited amounts of vaccine and you want to protect the elderly who are at highest risk from complications from flu, you can actually do the best job of that when supplies are limited by giving none of it to the elderly and giving it all to school-age children who turn out to be the primary transmission pathway. But that's a very counterintuitive result and a scary result for a policymaker to act on without having confidence in the model. And there are lots of strategies for how to do that. And finally, I think it's really important to keep repeating this idea that models don't remove uncertainty and they don't replace judgment. And having the right expectations about what a model can and can't do going in is extremely important, and it becomes even more important when you're trying to interpret what a model is telling you at the end. For model consumers, and by that I mean decision makers who want to use models as an input into their decision process, it's important to think about appropriate uses for models, and we didn't spend a lot of time in my talk on purpose, talking about the enormous diversity of types of models that are out there. You're going to hear a lot about different types of models today, but I was tasked with talking about modeling generally. But different models are good for different things, and making sure that you have the right kind of model for what you want to do is important. Engaging in design is important for policymakers for all the reasons that I just elucidated. Asking the right questions along the way to make sure you understand what the model is doing and why design choices were made can be very important. And finally, this point about interpreting models appropriately. So I'm going to stop there, see if there's any direct questions for me, and then I think we're going to have a discussion with the panel. Is that right? Q&A session. Okay. Thank you very much.